So our speaker tonight is Dr. Mark Dunbar. He's been a member of the optometric staff at the University of Miami's Bascom Palmer Eye Institute for over 30 years and currently serves as the Director of Optometric Services. He has served on the Conference Advisory Board for Vision Expo for many years and is finishing his term as co-chairman. Dr. Dunbar is a fellow of the American Academy of Optometry and is a founding member of both the Optometric Glaucoma Society, OGS, and the Optometric Retina Society, ORS. Dr. Dunbar serves on the editorial board for Review of Optometry, where he has written the monthly column, The Retina Quiz, for over 20 years. In 2021 and 2022, he was named as one of the top 150 optometrists in the nation by Newsweek magazine's annual survey. It's such an honor to have you, and we're really looking forward to learning from you tonight.
Thank you, Elise, and thank everybody for attending. You may not know this, but I'm looking at the participants, and there's over 700 people listening in. So that's quite an audience, and perhaps maybe one of the largest groups that I've ever lectured to, and certainly very intimidating. By way of financial disclosures, here is my list. Really, the real financial disclosure is this: that nothing I say in this lecture will have been an original thought. I have shamelessly copied and pillaged almost every thought or concept discussed. I am certainly not smart enough to kind of come up with many of the things that are happening really in the area of macular degeneration. And it really has been kind of an incredible time over the last really 10 to 15, 20 years since the beginning of really the anti-VEGF drugs for the treatment of choroidal neovascular membrane to now finally having a treatment for geographic atrophy. And as of February 17th, about a month ago, the FDA approved Syfovre, which is pegcetacoplan, as an injection for the first and only treatment for geographic atrophy. And I think many of us can relate to seeing that patient with GA who's been in our exam chair as we've sat helplessly, really watching this disease rob our patients of their central vision, rob them not only of that, but their independence. We've seen these patients slowly go downhill as they really lose their independence, their ability to drive, their ability to do things that they enjoy every single day, right? And finally, we have hope. And we're probably going to have a second FDA-approved medication by August. So truly, it is an exciting time, and we'll talk about these new drugs as we go through the next 50 minutes. We'll hopefully get through kind of the next generation anti-VEGF drugs and really the role of optometry in really on the front lines of this disease. So it is exciting, and I'm excited to be able to bring you this talk. So Syfovre, FDA approved in February, approved for all patients with GA with the dosing flexibility of every 25 to 60 days. If anybody has an interest in retina, let me put a shout out to Jay Sridhar. Jay is one of our retinal specialists at Bascom Palmer. He's going to be leaving to join UCLA beginning in the summer. But Jay does a weekly podcast called Straight from the Cutter's Mouth. And it comes out once a week. And when Syfovre was FDA approved, he did a kind of a short blurb on it with Alan Ho. And then a week or two later, he did a little bit of longer version. But if anybody has an interest in this and really hearing from a couple of, I think, gigantic retinal specialists in the field and their thoughts on it, I think it's a pretty good podcast. Jay talks about a number of things, so I'll give a shout out to that. I try to listen to it every week, and he's got some unique perspectives. Again, if you're aware, there was a lot of news media about this. CBS News did a blurb on it, and unfortunately, in their blurb, they were not at all very complimentary to optometry in this, essentially saying that really patients with macular degeneration and GA need to see a retinal specialist, that if you really want a real eye exam, that's who you need to see. And again, they just obviously didn't get it, so it's not very flattering. But we know the difference, right? As optometrists, we are on the front lines of eye care, whether it's macular degeneration or diabetes or just routine vision care, right? That's really what we do very well. If you believe the AOA story that 85% of all eye exams are done by optometry, which I do, it's not surprising. There's lots of access points through traditional private practices, through big box commercial retailers, through OD, MD practices. I mean, there's all kinds of avenues that patients come in to seek eye care. And again, optometry being on the front lines. And, I think we're very familiar with macular degeneration. We see it pretty much every day in our clinical practices. We are the driving force between diagnosing, managing, making recommendations, whether it's a nutritional supplement, whether it's needing, to be seen more than once a year, doing imaging with OCT, FAF, even fundus photography, to, again, sending patients to a retinal specialist as they need to. So we know that it's a degenerative disorder that affects the macula. It is the leading cause of legal blindness in people over the age of 65. About 90% of vision loss from AMD is from choroidal neovascular membrane. The other probably 10 to 15% is from geographic atrophy. And when you look at this aging population, that number represents a significant percentage. For those people who have vision worse than 2200, again, about 80 to 90% have the wet form, 10 to 20% have the dry form. And so we know, of course, what the risk factors are, right? Age is probably number one. We can't stop that. And if you live long enough and have a certain set of genetic predispositions, you're likely to get macular degeneration. We typically see it in white Anglo-European descent, but we certainly see it in Asians and Hispanics. It's rare to see it in an African-American population. You think about the patients that we typically see, the profile, elderly over the age of 65 to 70, and that population of patients grew up smoking. So it's very customary and was socially accepted in that generation. So it is probably the number 2 risk factor for developing macular degeneration. Certainly family history plays a role, as we've alluded to. And again, that genetic predisposition, we will get into some of that as we go along, particularly complement factor 8 and some of the other genes that mediate this disease, macular degeneration. Here's a few other factoids, right? 1 in 3 people over the age of 75 will be affected by macular degeneration. As we know, patients are living longer, and so that number of people over the age of 75 is steadily increasing. Look at that other kind of statistic, right? 10,000 people a day turn 65 in the United States every single day. That's a staggering number. And we know as we age, not only are more patients likely to develop macular degeneration, but you look at other diseases like glaucoma and diabetes and diabetic retinopathy and dry eye and cataracts. And again, to me, that's exciting, right? So as optometrists on the front lines of this disease, with the evolution of imaging and therapeutic interventions for both, anterior segment disease, glaucoma, in the era of macular degeneration, again, it puts us, I think, in the perfect spot to be able to diagnose, manage, and follow many of these patients. Certainly, the advent of OCT, I think, has really leveled the playing field with certainly the retinal specialist in terms of being able to diagnose and manage. And so again, when you look at these factoids in an aging population by 2025, which probably when I developed this slide 4 or 5 years ago, that seemed like a long way away, but fact is it's in only a few years, and 44% more people in this high risk category are at risk of developing macular degeneration. So you look at this projection between now and where we will be by 2015. Again, you look at the population in total, but in particular, it's the white Anglo-European that's at the greater risk of developing macular degeneration. And, Hispanics and the Black population, far less of a number, but certainly it is significant. And so why do some people get macular degenerations and others don't? And so I think, as we know, it's really mediated in part by genetics, a particular set of genetic markers like complement factor H, like ARMS2, which we'll talk about, other genes associated with lipid metabolism and whatnot. Also environmental lifestyle factors. So that interaction between genetics and environmental lifestyles really predispose patients to developing macular degenerations. And we know that there's been great treatments for wet AMD. They've been highly successful, but perhaps when you look at durability of the traditional anti-VEGF medications, not very well. And when we really look at the numbers, in fact, though they're successful, maybe not as successful as we truly believe. And we're now in an era where we've got these 2nd generation anti-VEGF drugs that we'll hopefully get a chance to talk about. But really, it's kind of where we are with the dry advanced form of macular degeneration and geographic atrophy. And so again, from a clinical perspective, drusen are the first clinical features, arguably, that we see in macular degeneration. They are extracellular deposits that lie below the retinal pigment epithelium. They compromise lipid and protein-rich debris. The fact is, they are a byproduct of abnormal metabolic activity. And again, coupled with this genetic predisposition and environmental lifestyles factors lead these patients to develop macular degeneration. When you look histopathologically of these drusenoid deposits, 40% of them are composed of lipid, but really other things like lipofuscin, albumin, other things, and including end products of this complement cascade, which we will get to in a little bit. Drusen are dynamic, right? So, I kind of think back of the 80s and 90s where we would watch these drusens very carefully. If you recall, there were, studies, light laser, trying to, can we get rid of the drusen? And we would think that if we could get rid of the drusen, that would be a good thing. The fact is, drusen are dynamic. They will come and go on their own. This is a patient that I saw, probably 15 years ago, who also a glaucoma suspect. You see large coalesced drusen. And I was surprised when I would follow him again. I would see him twice a year for his really kind of a glaucoma suspect and intermediate AMD. And what I noticed over a period of a few years was that, the drusen end up kind of going away. And then the question was, well, he was on an ARED supplement. Was it because he was on these nutritional supplements? Is that the reason why the drusen are going away? And we kind of thought that was really a good thing. But the reality is we now recognize that, again, part of that evolution, these drusen collapse. And it really becomes really a marker for the disease getting worse. And what ultimately happened to this patient was he goes on to develop geographic atrophy. And you can kind of start to see that in this clinical photograph. And so I think one of the messages that I really want to relay tonight is how important it is to stage macular degeneration. Just like, we stage patients who have diabetes and diabetic retinopathy, we stage macular degeneration, that early, maybe a few drusen, small drusen or druplets as we call them, the intermediate level AMD where there's a certain size of these drusen, in addition to maybe RPE modeling. And we'll talk about really what constitutes somebody having this categorically intermediate AMD and really how important that is to our practice, right? This is really the stage where you begin to recommend a nutritional supplement. This is the stage where I typically start to see patients at least twice a year. Again, with imaging, we talk about, again, nutritional supplements and those type of things. And of course, we know once they develop that intermediate level AMD, they can really go down two paths, right? They can either develop geographic atrophy or they go on to develop the wet neovascular form of macular degeneration. And really our attention, at least with imaging, has been really monitoring that patient from that intermediate level to going on to convert to the wet form of the disease. So I think we get OCTs on these patients. We watch very carefully. Is there any fluid? Isn't there any evidence that this patient has really converted from dry to the wet form of the disease? This is the Beckman classification of AMD. And again, really 4 stages, beginning with no AMD. And even without AMD, you can have a couple of these small, tiny drusen that they, describe as druplets. There's the early form of AMD where, again, more medium-sized drusen, anywhere between 63 microns to 125. And I recognize, we talk about microns and what clinical relevance and practicality is that. And again, I don't think it really matters as much until you really reach this intermediate level. And again, once you reach intermediate, you have at least one drusen that's about 125 microns in size and or any really pigmentary abnormalities. And of course, we will get into the kind of the advanced forms in just a second. So what does 125 microns mean, right? And so to me, any drusen that is about the size of one of the branches of one of the major retinal veins, that is about what 125 microns is. And so if you see drusen that are at least the size of one of the branches of one of these branches of the central retinal vein and or pigmentary abnormalities, again, categorically, that puts a patient at an intermediate level AMD. Again, you look at the one on the left here, right? These large coalesced drusen with RPE abnormalities. Again, before OCT, I'm really not sure how effective we were at really looking at these patients with just, biomicroscopy, right? Trying to, determine, is there any fluid or is there any elevation? And that was really hard to do. And again, now that we have OCT, I think it's really taken the guesswork out of it. But I think you can recognize very clearly this is an intermediate level. And even though they don't have choroidal neovascular membrane at this point in time, we know that that patient's risk over the next 5 years is probably at least 50%. And so that becomes a very important patient to be able to watch at least twice a year, maybe 3 times a year, following him with OCT imaging, recommending nutritional supplementation. Even the one in the middle, it's not quite as bad, but you see how large these drusen are. The one on the right, that may be a little harder, right? Whether that's an early level, or maybe you look at some of the size of these drusen and you can maybe kind of fit it into this intermediate level. It's important for ICD-10 coding, right? When you, use an AMD, ICD-10 coded, they ask you what level of AMD it is. And again, this is the patient that I think about prior to having an OCT, how hard and difficult it was to answer the question, is there a choroidal neovascular membrane? Is there any fluid? And again, sometimes we just go by acuity, right? They're 20/20, they're doing pretty well. They don't have any symptoms. And you'd kind of, again, I don't see hemorrhage, I don't see exudate, and you would hope that you were right in terms of your assessment. And so, again, this is part of that Beckman classification. And this becomes interesting, right? Because once you reach that intermediate level, and this is AREDS data from 10 years, right? Looking at the fact 10 years down the road, they've got about a 48% risk of going on to develop choroidal neovascular membrane. And yet, when you look at their risk of going on to develop geographic atrophy, it's in fact higher, almost 54%. And again, I'll tell you, when I saw this statistic, and it's been around for a while, I didn't really believe it. I thought, there's no way that the risk of going on to develop GA is higher than the risk of going on to develop wet macular degeneration. And I think the reason is in part, this is the image that we conjure, right, of geographic atrophy, that large disciform scar. And the fact is, at least in the ARED study, they looked at really all levels of geographic atrophy. So, not everybody had this large disciform scar. Many of them with intermediate level AMD had small patches. And so when they looked at the totality of that group, in fact, the risk of going on to develop GA was higher than it was of developing choroidal neovascular membrane. And since really there's been so much attention on GA, as I've kind of looked at many of my AMD patients, what I recognize is even small levels of GA is present. As I've been better at really looking for GA with OCT, with fundus autofluorescence, and we'll kind of get into this a little bit later in the talk, the reality is that it is much more common than that we really, I think, realized. And so one of the message that we're going to get into is really, I think we need to do a better job of recognizing GA, because now we have a treatment. And so one of the discussions, when do we need to get these patients to a retinal specialist for potential treatment? And so we know that geographic atrophy is the advanced late form of dry macular degeneration. It represents atrophy of the RPE and photoreceptor segments. And again, this is the image that we conjure, right? This patient who's got large central GA, we know that her acuity or their acuity is worse than 2200. And this is a patient, especially if they have it in the fellow eye, again, their independence, their ability to drive, their ability to enjoy life is really greatly compromised once you've reached that level of GA. So yeah, is it more common than we thought? Do you really believe that data? And as I said, when I first heard that, I go, there's just no way. Or wet AMD is definitely more prevalent. And I think the fact is we just haven't been looking for it, in part because there really hasn't been a treatment. And again, I think most of us, when we follow patients with macular degeneration, especially the intermediate level, really our focus has been really detecting that conversion from dry to wet. So when I look at and do OCTs and look at these B scans, is there fluid? Is there any elevation? Do I see choroidal neovascular membrane? And the fact is, you look at a patient like this, right? And I don't have the OCT up, but the fact is, if you look at the color image, there is some early geographic atrophy that's present that, again, if you weren't looking for it, you would easily miss it. And many of us don't have fundus autofluorescence, but you look at the fundus autofluorescence image and you can see a couple patches of GA. And so this is a patient who's 20/20. They're relatively asymptomatic. They're on an ARED supplement. We're following 2 to 3 times a year. And again, the focus has been that conversion from dry to wet. But the fact is, they've got little patches of GA that also needs to be monitored and watched. And if it looks like it's progressing, and certainly if it's progressing towards a phobia, this is a patient that now we need to refer to a retinal specialist and begin having the discussions regarding treatment. And so, yes, it often starts small, extrafoveal. Unless you're looking for it, you really may not be aware that it's even present. And again, you look at kind of who is at higher risk of developing. We've talked about really some of the genetic factors, white Anglo, but it also is a manifestation of age, right? We're going to see it in that 65 to 84-year-old patient, but the fact is, it's really the minority. It's really the patient, once they reach the level of 80 to 85, you really look at the prevalence of geographic atrophy certainly exploding. And again, I'll bet within the last week, we've probably all had patients in our exam chairs that are in that 90-year plus age range. Both of my mom and dad lived to 94. Fortunately, they didn't have AMD or geographic atrophy, but that's not an uncommon patient in our exam chair. And though the wet form of the disease, we typically see that 65 to 75 and 85. It's really once you reach that 80, 85 where, it's more commonly we start to see geographic atrophy. And so one of the issues is, we really haven't had good ICD-9 or ICD-10 coding. If you kind of categorize bit by ICD-9 or ICD-10, it's central geographic atrophy, right? And as we've just talked about, many patients with GA, it's going to be extrafoveal. And so it's difficult to really know how common or how prevalent it is. There isn't great population studies to really help us and guide us. Here's a study out of the United Kingdom looking at 10 clinical sites between 2000 and 2016. And again, when you look at patients who were diagnosed in both eyes with geographic atrophy, you look at how rapid it progressed over a period of 2 years. They were more likely to lose on average 6 to 10 letters of visual acuity. And look at this one, right? These are people that at the time of diagnosis were able to drive a car and really functioning very well. And within 2 years, 2/3 of them progressed to vision loss that rendered them ineligible to drive. 20% or 1/5 after that 2-year period ended up being legally blind from geographic atrophy. This is a Harris poll that Apellis did in 2022. Again, really looking at the impact on the quality of life of patients with geographic atrophy. 7 in 10 believe the impact of their independence and quality of life has declined much worse than what they expected. And majority felt the disease negatively affected their ability to read, drive, and travel. And one in 3 recently have withdrawn from activities. So again, I think those that are listening in, and that's not a surprise. I mean, we see that patient, right? As they're kind of marching through their 70s and 80s, they're already, their health isn't as well. They've, many of them have quit driving anyway, just because, again, their vision has gotten compromised. They don't feel confident. They've got other, ailments going on. And when you look at really the impact of vision, that's just one more thing that really, I think results in patients having major depression. And again, that inability to enjoy life and doing the things that they really like to do. And so when you look at, pathophysiology and really understanding this disease, I don't think there's really any diseases that we have a better understanding of the genetics than in macular degeneration. With some of the genome-wide studies that have been done, we really recognize there's two drivers of this disease. There's the complement factor H gene, which really accounts for maybe 40 to 60% of the hereditary or heritability of macular degeneration. And really the other one is the ARMS2 genes. And then there's, genes affecting cholesterol metabolism, genes affecting the extracellular matrix. But really, it's these 2 drivers that really lead a person down to this development of macular degeneration. And we'll kind of dive into really the role that complement factor H plays in here in just a second. So you're going to hear a lot about it because, the complement system really is a target of macular degeneration in particular, really a target of really trying to stop and treat a geographic atrophy. So it's one of the body's primitive defense immune system. It is really the first line of defense in our immune system. It's made up of a group of proteins that mount inflammation, they destroy foreign invaders, they remove debris that results from some of that destruction that develops as a result of our immune system really trying to fight and heal itself. And so complement factor H is the gene that gives instructions for making factor H. And factor H is really, it's an important inhibitory regulator of this complement system. And so, and again, we're going to probably spend a little more time than what anybody's really interested. But again, it's really, I think, in part important to understand really why people develop macular degeneration, why when we look, therapeutically, why this is really a key strategy, particularly in geographic atrophy. And so there's really three ways that this complement pathway gets activated. It's, through the classical pathway, which is really, again, a kind of what is the word I'm looking for? Yeah, an antibody antigen kind of complex pathway. The alternative pathway is really probably the main driver in macular degeneration. And then there's this lectin pathway, if you will. And once this complement pathway gets activated, there's really kind of three kind of wave stations, if you will. There's this C3 wave station where you get this kind of amplification of this complement pathway. And then there's the C5 convertase stage where, again, it leads to this terminal pathway, which ultimately leads to membrane attack. And again, inflammation plays a key role. And the idea is that with macular degeneration, there's a normal homeostasis that occurs in all of this complement pathway. And what happens in AMD, there's loss of this homeostasis. There's this dysregulation, if you will. And the reason we know that is when we've looked at drusen histopathologically, we've seen some of the end stage products of this complement pathway. So we know that complement factor H is really kind of a key driver just by looking histopathologically at some of the end products, histopathologically of macular degeneration. Think of almost like a stick of dynamite, right? You light a fuse, and as that fuse goes, it really starts a chain reaction that ultimately, when you're thinking of a stick of dynamite, it blows up. And if you will, that is membrane attack. Membrane attack is really within the RPE cells. And so when you think of this dysregulation of the complement pathway, it's really the stick of dynamite that's really trying to kind of treat itself, trying to kind of rid itself of some of the debris and some of the things that happen in macular degeneration. And of course, there's going to be some collateral damage. So the idea that if we can regulate this complement pathway, and again, this is a busy slide, but again, the end result of many of these therapeutic approaches is to really slow down or stop this dysregulation of the complement pathway, ultimately stopping membrane attack from really having its destructive forces that it occurs. And so, again, lampalizumab was a drug that was a factor D inhibitor. That was a drug that was really, again, one of the first drugs targeting geographic atrophy. It ended up not getting approved by the FDA. The Apellis drug, pegcetacoplan, is a C3 inhibitor. We'll kind of dive into that in a second, but it is really, again, attempting to stop the complement pathway at this stage. Avacinacaptid pegol is the Iveric drug. It is a C5 inhibitor. And again, we'll kind of dive into that a little bit, but really the goal is to really end up stopping or inhibiting membrane attack complex. And so, again, this pegcetacoplan, as I talked about, is a C3 inhibitor. The idea that if we can stop it here, we can stop really all the downstream effects of membrane attack, stop cell death, lysis or proliferation that occurs really on a microscopic or biocellular level, stopping inflammation and some of the things that, again, that drive macular degeneration. And so they were really the first out of the gate. And if you look at really the phase 2 clinical trials, the Philly trial that really essentially got everybody excited. And so this is an anti-vitreal injection, and pegcetacoplan or Apellis really looked at every month injections versus every other month injections. And this is really probably one of the first studies that vision was not part of the equation. You look at every study that's been done on eye care, and again, the goal is visual improvement, visual recovery. And when you're looking at geographic atrophy, this was really not the goal. The goal was really reducing the progression or the size of geographic atrophy. And so when you looked compared to a sham injection, this was over a 12-month period, every month versus every other month, we could really see that the drug did a fairly good job of slowing down the progression of geographic atrophy. And of course, the phase 2 clinical trials led on to really the phase 3 clinical trials that about a month or so ago led to FDA approval. And so you had, again, a monthly group versus an every other month group compared to really a sham injection. The primary endpoint at 12 months was, again, this change in total area of geographic atrophy. And the benchmark was really looking at fundus autofluorescence. At 24 months, they started looking at some of the visual indicators, reading speed, microperimetry, again, size of the geographic atrophy. And so this was really the 12-month clinical data. You can see in the Derby trial a 13-month reduction in the size of geographic atrophy compared to the sham injection. And then you look at, this was the every other month. This was the monthly versus the every other month. I'm sorry. So 13-month versus every other month. And in the Oak study, it was a 22% reduction compared to every other month injection. And what's interesting is, when you look at the primary endpoint, remember, FDA requires 2 parallel FDA clinical trials. The Oaks study, that study met their endpoints. The Derby study did not meet the endpoint. But interestingly, as the study went on, so again, pegcetacoplan every other month met the endpoints. The Derby study, it didn't. But when they really looked at their 18 to 24-month data, they really could start to see an accelerated effect of the treatment in those eyes that were treated versus those eyes that were not treated. And so one of the kind of the messages, right, is here's a patient that you and I see that has geographic atrophy. And it's important to note that at least in the Oaks and Derby, 60% of these patients were subfoveal. So these were patients who already lost a significant percentage of central vision. About 40% were extrafoveal. So that's why in part vision really wasn't really a factor. It was really looking at slowing the growth rate of this geographic atrophy. So think about it, right? You're looking at 6 to 12 months, about a 20% reduction in every month, 17% reduction by 12 to 18, maybe a little bit better, but where you really start to see the improvement in reducing the growth rate of geographic atrophy, if you will, is at 18 to 24 months. And so, you take a step back, right? And it's not very impressive. And remember that this is at least in every month, maybe every other month, to get about a 22% or so reduction in the growth rate of geographic atrophy. So this isn't a cure. This isn't something that's going to cure this disease. This is something that will slow it down. And so again, you look at that 12 to 18 months, counseling our patient that it's going to be every other month, that you may not have or see a benefit, because theoretically, if we catch these patients that are extrafoveal, they typically, hopefully they'll have good acuity. They're not doing this because we're going to see a visual acuity benefit. We're going to hopefully prevent this disease from progressing at a rate where it starts to rob them of their central vision. So a month or every other month for a year and a half, probably not going to see a benefit. But what happens kind of as you kind of go out 24 months, 36 months, you really start to see this delta, if you will, start to expand or increase. And so, again, the longer you go, the delta gets wider and the treatment effect gets greater. So, part of the message is, educating our patients, letting them know that, the goal is really to prevent this disease from really affecting your central vision. And again, it may be, a lot of injections really before we get there. So again, not a cure, just slowing the growth rate. So again, some of the takeaway points, the primary endpoint was change in geographic atrophy lesion size. There was no prevention of vision loss because, again, many of these patients started out with poor vision. And again, we're not making it better. It's just getting worse more slowly, and hopefully slow enough that it really allows them to have a good quality of vision for the remainder of their life. And no question, it seems like there is the longer the patients are on the medication, it takes a little bit longer to see, a treatment benefit. So I think that's kind of an important perspective. And the question that really retinal specialists are asking, we're all asking, is that is that a significant enough treatment benefit for somebody who, again, 80, 85, 90 every single month to have a 20 to 30% slowing the growth rate of the geographic atrophy. And again, I think, time will tell how this gets embraced by the retina community. In the meantime, I think as OD providers, I think it's important to recognize, diagnose, and make sure patients are still getting in to see their retinal specialist. So again, treatment effect was accelerated between that 18 to 24 months. And I think that's kind of the important point. Let's talk a little bit about avcinacaptid pegol. This is the other drug that will likely become FDA. They've got their PDUFA date, I think, in August. And so where Syfovre was a C3 inhibitor, this is a C5 inhibitor. And I'll tell you, the data in this drug, to me, looks a little bit better than what we were seeing in Syfovre. We're looking at about a 25 to a 30% or so reduction in geographic atrophy growth size. The big thing about C5, right, is maybe it's a little further downstream, but when you look at particular at geographic atrophy, C5 really seems to be one of the great mediators. And again, some of the end products, it's a mediator of inflammation in geographic atrophy. And again, the idea that we can prevent membrane attack formation from occurring, again, may potentially maybe another avenue for treatment. And so again, this is the GATHER1. They have a GATHER1, GATHER2. And I think what we're looking at is, again, they looked at two different concentrations of avcinacaptid pegol, a 2 milligram and a 4 milligram. The two ended up doing pretty much just as good as the 4 milligram dosing. The interesting thing is these were people who, again, I think they had more extrafoveal lesions. These were people, they didn't really look, at least in that first 12 months, at an every other month dosing. They looked at every month dosing. And then after 12 months, again, we're able to, one group gets every month, one groups get every other month. And again, I think there's finally some, 12 to 18 and 24 month data. And by the way, this is the first clinical trial, at least looking at geographic atrophy, where both GATHER2 and GATHER1 did meet the primary endpoints in the clinical trial. So this is in the hands of the FDA. I think, again, we're looking potentially at maybe a little bit better than what we were seeing with Apellis. But again, I think in both studies, the longer you go, the delta increases in the therapeutic effect, I think, increases the longer the patients are being treated. Now, the one interesting tidbit, right, in both of these clinical trials is in the eyes that were treated with the drugs, they were more likely to develop in the course of the clinical trial choroidal neovascular membrane. In the Iveric study, about 7 to 9%. In the Apellis study, you're looking at about, in the monthly group, 7%, in the every other month, 3% to 5%. So again, that was more than what we were seeing in the sham injection group. So the idea is as we're kind of treating the geographic atrophy, we also need to continue to monitor these patients for developing choroidal neovascular membranes. So again, uniquely different kind of outcomes in both treatment groups with the pegcetacoplan and the other drug. And so how do we diagnose it? Let's spend a few minutes talking about that, right? So color fundus photography has been around forever. We'll talk about the strengths and weaknesses. In the clinical trial, autofluorescence was really, in fact, blue peak autofluorescence was really kind of the main barometer in not only diagnosing, but managing progression. And the problem is, many ODs and comprehensive ophthalmologists don't have autofluorescence. Many of us have OCTs. And so part of it is really going to be looking at how do we kind of look at these OCTs and really being able to do a good job of capturing the presence of geographic atrophy. And in part, really looking at the en-face image or the near IR image, as well as looking at certain markers on the B scan. And so the problem with fundus photography is really, you really lose some of the contrast, right? I mean, you can kind of recognize it, but it's a little bit more difficult. Here's a patient where you looked at, right? It's kind of a busy slide. There's a lot of drusenoid change. And the fact is, this patient has a little bit of geographic atrophy that easily gets missed. So one of the problems, again, insufficient contrast. And again, when you look at OCT, right, is we've been kind of looking at these B scans, as we talked about earlier, looking at is this patient really converting from the dry form of the disease to the wet form of the disease. But the fact is, there are some markers that we need to start looking at on our OCT to be able to detect the presence of geographic atrophy. One in particular, right, looking at the en face image, and it correlates actually very well with fundus autofluorescence, looking at these transmission defects. And we'll talk a little bit about that as well. But looking through the B scan, right, you've got loss of the RPE, the photoreceptor cells, and you're seeing a very typical transmission defect that you can see on the B scan. Here's a patient that I have been following for probably 3 or 4 years, right? He's got typical macular degeneration. And as I said, my focus has really been on this conversion from dry to wet. And so I see him twice a year. And, his last visit, this was in January 2023. Once I started becoming aware that we're going to have a treatment for geographic atrophy, you start looking at the B scan, right? And you start to see some of the transmission defects. And again, you look at the en face image, and quite honestly, I really have not been focusing on that. And yet, here's a patient over a year period. You can see that his geographic atrophy is clearly progressing. And so this is a patient now that not only are we worrying about conversion from dry to wet, but this is a patient where we now also need to be watching his, geographic atrophy, and perhaps not sending him to a retinal specialist for a treatment for the wet form, but perhaps this may be a candidate for one of the newer medications. Again, we're not going to have time to talk about some of the consensus definitions, but there is something you're going to hear a lot about, C-RORA, which is complete RPE and outer retinal atrophy. And again, by definition, a hypertransmission defect of about 250 microns, so about a quarter. Well, remember, a disc is about 1,500 microns, so you can kind of figure out how big that is. And I think this kind of image shows it really very nicely of what you would look for somebody who's got complete RPE and outer retinal atrophy. I think one of the other messages is really starting to look at some of the biomarkers, right? And so when we're looking at these B scan, these biomarkers may help us predict both those patients that are at risk of conversion not only to wet macular degeneration, but also conversion to geographic atrophy. So some of the things have been looked at, right? Higher drusen volume, increased drusen height. These are things that, again, you can kind of see on the B scan. Abnormal thinning of the retinal pigment epithelial layer. There's also a host of other ones, things that, again, over probably a couple of years ago, I hadn't been paying attention to, but now, again, now that we're looking more carefully at some of our OCT images and recognizing that these biomarkers are really risk factors for conversion, these hyperreflective foci, these reticular pseudodrusen. We talked about, complete, C-RORA, but there's also incomplete RORA hypertransmission defects. And again, here's a patient, right, where you look at these little dots, these little particles that are suspended above the RPE. This is a hyperreflective foci, these extracellular pigment granules and outer segment debris. And again, in the ARID study, patients who had these hyperreflective foci, they had really a 5 times increased risk of progression to geographic atrophy over a 2-year period versus control. So again, you see that's a marker that this is a patient who's got a higher risk of progression to both geographic atrophy, but the wet form of the disease, right? See these drusenoid PEDs, right? And you look at these little hyperreflective foci, that is a marker. And this is a patient who goes on to, I think this is a couple of years later, goes on to develop wet macular degeneration. They got a little kind of choroidal neovascular membrane that's present there. And again, this is after multiple anti-VEGF injections. But again, you see these hyperreflective foci that really are markers. These reticular pseudodrusen that lie just above really the retinal pigment epithelium, often can see superior to the macula as the scan here. And again, when these reticular pseudodrusen were present, a 2 to 6-fold increase in the risk of progression either to neovascular macular degeneration or central geographic atrophy. I don't have an OCT scan of this one. I wish I did. I looked for it, but these are these very typical reticular pseudodrusen. Here's a patient again, right? I think we've looked at, the color fundus photographs. You can kind of see he's got some focal areas of geographic atrophy. And again, this is the right eye. You see this hyperreflective foci. You see on the en face image, these areas where the geographic atrophy is present. You look at the B scan and you see this hypertransmission defect. What about here, right? This is the right eye. We kind of talked about that. And you look right here. Looks like RPE is intact, but this represents a hyperreflective column. Again, that is another biomarker that we now know that puts patients at a higher risk of going on to develop progression. So this narrow strips of light, what looks like in the presence of an intact RPE. So again, present in 20% of eyes that progressed to geographic atrophy and neovascular AMD. So again, an important biomarker in this disease, right? Again, you look at little patches of GA, kind of see the hyperreflective foci there, and guess what? You got these kind of hypertransmission defects. So again, we've been looking at these B scans. Is there fluid? Is there conversion from dry to wet? But there's key markers, biomarkers that really help us predict that this is a patient who's at a higher risk of going on to progress. And in this case, right, you can look, this is a patient over, 6-year period. You look at the size of the geographic atrophy, and this is a patient who goes on to really progress to the point now that he's 20/60. And this is a patient that we know, and really he's got this little island left of his macula. And this is a patient that we've watched hopelessly, see this disease rob them of their central vision. And, I haven't seen the patient in a year or two, but I think we all know what happens to this patient, and unfortunately. Again, Olga, another 2020, right? You see these coalesced soft drusen, and guess what? Little hyperreflective foci here puts this patient at a little bit of a higher risk. Some of the OCT machines have this RPE sub-illumination map. The Zeiss Cirrus has it. I think, all the OCT companies will develop it. But again, it's a way to really kind of document and mark the presence of these drusen. And again, even it can mark the presence of geographic atrophy. I'll show you a case here in just a few minutes here. This is, again, patient that I have been following, twice a year, has dry AMD. She had cataracts. I referred her to cataract surgery. She comes back after cataract surgery. Here she was in September 2025, reasonably happy. And again, you look at some of these hyperreflective foci, right? These transmission hyperreflective columns. So this was September. She comes in November, and she's starting to have distortion in the right eye. And what you're going to see is, again, more hyperreflective columns. She's 20/30. Here she was in March. 4 months later, still distortion. What you're going to start to see is she's got little patches of geographic atrophy. Right? I do the OCT and I can see these hypertransmission defect. And she's symptomatic. 20/30 is good, but boy, she knows it's changed. She knows it's getting worse. And again, from November to March, and remember, we just had a geographic atrophy drug approved about 2 weeks ago. So guess what? And again, here's her fundus autofluorescence with a blue peak, and you can see these little patches of GA, and she's got this little central island. And again, we look at our kind of sub-illumination map, and you can see that it shows up, right? This was the prior visit. This was the visit now, and it's starting to show up. And so, yeah, I had the discussion. Guess what? We have a treatment. I talked about it. It's every month, maybe every other month. Takes a little, little while to see a therapeutic benefit. She goes, send me. If there's a treatment, please send me. She bought into it, which I think she's kind of one of the rarities of patients who kind of knowing that this isn't every month, it's an intravitreal injection, but I'll tell you, she wanted it. And again, I don't know if she's seen the retinal specialist yet, but she is in line. And so very quickly, we'll talk a little bit about, fundus autofluorescence. Blue light autofluorescence in particular is really probably one of the most important applications of fundus autofluorescence. This was really the benchmark in all of the geographic atrophy trials. There's looking at different patterns and shapes of geographic atrophy. Some are, higher risk than others. Again, for the sake of time, we're probably not going to get a chance to spend a lot of time on it. But this is, again, I think you can see in this patient, very classic progression of geographic atrophy. Some of the clinical trial data, right? 2.5 times the median time to develop central geographic atrophy after the diagnosis. It takes about 7 years on average to develop bilateral geographic atrophy after the development in the first year. And so again, this becomes important because now we recognize that there is a treatment for this disease and patients need to get sent to the retinal specialist in time. Here's end our discussion on this one, right? At least on geographic atrophy, patient I don't see her yet. This is 2011, and I think you can see she's got these small little drusenoid changes. I would probably call this early macular degeneration. She's in her mid-60s at this point. She's very active, as many 65-year-olds are. She walks, she drives, active with her grandkids. She's, really does it all. Fast forward 10 years, right? And this is the color fundus photograph that really probably doesn't do it justice, but you do the fundus autofluorescence, and clearly you can see the shape and outline of her GA. And even at this point in time, she's 2040 and 2060, she is still active. She was driving, she was, walking. This was a lady who was enjoying life. And so you kind of think back to June of 2021. This is a typical patient that we've all seen, right? And you talk about low vision, magnifiers. We try to optimize the vision she has, but we know what's going to happen to her, right? And unfortunately, after the approval, and this is again just kind of a close-up, you see this little island, right? 2040, 2060 in this eye. Well, guess what? She comes in February 27th, about a month to 2 weeks after FDA approval of this drug, and now she's 2,200 in each eye. And the daughter brings her in, and again, you know how the discussion is, right? She's lost her independence. She's not walking. She's trouble doing things that she enjoys doing. So again, you kind of look at that really year and a half period of this very typical progression of geographic atrophy, robbing her of really her central vision. And so really having the conversation of unfortunately there is a treatment, but probably at this point in time, she's not a candidate. Would you submit her to monthly injections to really take a year to 18 months to really see a therapeutic benefit? And that was kind of one of the sad discussions that I think we all have with our patients. And fortunately now, there's hope. There's hope that we can really offer something for our patients that really can offer something, right? And I think we're kind of, where are we today, right? We have an FDA-approved treatment. I think by August, we will likely have a second treatment. This is a monthly intravitreal injection, maybe every other month. The indication by the FDA for Syfovre was 25 to 60 days. And it was really all forms of geographic atrophy. So remember, it takes about 12 months to really show any significant therapeutic benefit. But really, if you can get them through that 12 to 18 months, I think what we start to see is a treatment effect begins to accelerate. And keep in mind that many of these patients, when we see them, at least extrafoveal, they should have really very good visual acuity if we can catch them in time. And so the goal is to slow it down enough where patients can really enjoy good vision for a lifetime. I think I have about 5 minutes, right? Elise, let me talk very quickly about kind of where we are with wet macular degeneration. Just a perspective, this was the 1990s. This was a study by the National Eye Institute of patients who would come in with subfoveal choroidal neovascular membrane. And the idea is that we're going to laser the fovea, and somehow or other, the treatment scar that results from the laser is going to be smaller than what would happen with the natural course of the disease. Never mind that lasering the fovea is going to automatically result in a visual acuity of worse than 2100 to 2200. And you think about how barbaric, that treatment was, and really where we are today with anti-VEGF. And as good as they are, right, they require frequent injections. Again, we may be able to control the wet form of the disease, but it's also important to note that about a third of those patients who are treated with anti-VEGF drugs, about a third of them lose vision because of geographic atrophy. So these anti-VEGF drugs really don't do much, really do nothing to control geographic atrophy. And what we're going to learn is really over the course of 3 to 5 and 7 years, many of these patients end up losing vision. And again, when you look at clinical trial results compared to real world results, the fact is, the treatment outcomes fall short. And this is not just in the United States. This is data really from around the world, where that 30 to 60 days to 90 days, we see a pretty good therapeutic effect from these anti-VEGF drugs. But the fact is, over time, these patients lose vision, in part because of treatment burnout. Patients, every single month getting an injection. So really, poor durability of these drugs. And, one of the messages, right, we catch the disease really too far along. About a third of patients have visual acuity of 20/40 or better, which means about 70% at the time of diagnosis are in that 20/60 or worse visual acuity. And again, we're not going to have a chance to talk about this. I think there's great home monitoring modalities. I'm really very excited about the 4C home device. I prescribe this on my intermediate level AMD. There's great data to show both in the age-related eye disease study, but in really the iris registry data that patients who used the no-tell home device that were more likely at the time of diagnosis have a visual acuity of 20/40 or better. In that iris registry, over 83%. In the AREDS home study, about 94% compared to that on average patients 20/80. This is exciting, right? The same company has a home OCT device that we're going to be used to monitor patients once they've developed wet macular degeneration. So I think this is already FDA approved. It's really very sensitive in terms of detecting fluid. They will have an AI, artificial intelligence kind of attachment to it. So we'll recognize really when there's fluid that has been detected. I think when you look at some of the next generation treatments, Beovu was Novartis's drug. The idea that these were drugs that were going to be more durable, last longer. Indeed, they did a good job. The problem with the Novartis drug is, we started seeing really almost blinding cases of occlusive retinal vasculitis shortly after FDA approval. So unfortunately, retinal specialists really are afraid to use it. The port delivery system was, again, surgically implanted. Again, the theory is that you may never need an intravitreal injection with having this port delivery system. The patient will come in maybe every 6 to 9 months, get a refill into this reservoir. And again, the clinical trials showed that it worked very, very well. Unfortunately, this past fall, what they started to notice was really the septum displacement. So picture, if you will, a wine cork that gets pushed down into the wine bottle. And that's what we were kind of seeing with this port delivery. So they did a voluntary recall of the port delivery system. And so we'll kind of interesting to see what happens with that. And then finally, kind of the latest anti-VEGF drug, which is really a bispecific drug that not only inhibits VEGF, but it also inhibits angiopoietin 2, which is really a key driver that leads to the development of VEGF. And the bottom line, again, we're not going to have time to go through the data. This drug is the molecule's faricimab. Essentially, we're looking at just as effective as what we had with the anti-VEGF drugs, but these are drugs, instead of delivered every single month, you're really looking at maybe every 3 to 4 months. And again, the data from the phase 3 clinical trials, again, looking at probably 4 times a year drug. And so these are potent drugs. They're powerful drugs. You still kind of retinal specialists have to jump through hoops to get FDA approval of these drugs, get insurance approval of the drugs. But the fact is, or the point is, these are drugs that are going to last longer and result in our patients really needing far fewer number of injections than what traditionally has been seen. So to kind of summarize this, optometry plays really a critical role as primary eye care providers. I think the treatment of GA really represents a new frontier in the management of macular degeneration. It'll be exciting to kind of see, how this gets adopted and how patients adopt it. And again, I think from our perspective, really offering hope to these patients, something that will hopefully slow the disease down enough that they're able to kind of keep and maintain vision really for a lifetime. I think, all providers, comprehensive ophthalmologists, primary care optometrists, we all need to do a better job of GA detection. And I think there's going to be a lot of messaging around that. You look at companies like Iveric and Apellis, and they're really doing a lot of things really around GA detection. And I think that's great. Pay attention to some of the biomarkers that we talked about, really being risk factors for conversion. And again, we didn't spend a lot of time, but we're really kind of in the era of these next generation anti-VEGF drugs that are now available.